All right. So believe it or not, this is the last session of the symposium, and we're very much looking forward to hearing Lisa, more about her later. But I didn't want the day to end without going up to all of you one more time and thanking all of the participants, thanking all of the presenters, but more especially thanking the staff, and even more especially thanking Gayla for all the hard work that she's been doing in this, obviously, almost the whole year. But excited because this 2 days we have been reaching the world, and the world has been listening, and the world has been learning, and that is what drives us every day. And I just want to thank all of you that participated. Don't forget us. We're here for whatever you need. And thank you again, and we will see you next year. Thank you very much. Gayla.
And thank you, Emilio. So everyone, just a reminder, be sure to go ahead and open up your CEU form one more time and get that submitted today if you're finished, but you have until July 7th. And again, you'll see an email from us when On Demand opens. Our plan is to open it on July 25th, but if for some reason we cannot, we will certainly send an email to everyone. And we have a lot of work to do in between now and then just to make sure all the files come out correctly, so you'll be able to see the sessions in their completion. So again, thank you for being with us, and we'll look forward to seeing you next time. I'll turn the microphone over to our moderator, Dr. Yvette Sejas, for our last presenter of the symposium, Dr. Lisa Park, who I've been looking forward to seeing for a long, long time. And her topic of unilateral hearing loss, this is just going to be a delightful opportunity for all of us. Yvette.
Thank you, Lisa. And thank you, Gayla, actually, and Emilio. I'm super proud and excited to introduce the last keynote speaker for this amazing symposium. So wherever you're coming from in the world, please make sure to continue using the chat function and letting us know where you're from. If you want CEU's credit, just like Gayla mentioned, be sure to stay for the entire session and be sure to complete the assessment of learning on the CEU grid for this session. If you want to pose questions, please go ahead and use the Q&A function on your right-hand side of the screen to go ahead and let us know. Remember that you also have the captioning available as well as the different language translations, but I don't want to take any more time from our amazing speaker, Dr. Lisa Park, who is an associate professor in the Department of Otolaryngology at the University of North Carolina. And she's also the division chief of the Children's Cochlear Implant Center. Her clinical research focuses on expanding cochlear implant indications for children and optimizing outcomes from non-traditional pediatric cochlear implant recipients. I've also had the pleasure to listen to Lisa in several different settings and also work with her in other groups. So I know you will love her presentation, and she's super informative. So without further ado, I will pass it on to Dr. Lisa Park, who will be presenting on the unilateral hearing loss in children, cochlear implantation, and the benefits of bilateral hearing. Lisa?
Thanks so much, Yvette. Thank you all for the kind introduction and for having me here today. And thanks to all of you for hanging in there. I'm sure it's been a very long day, and now we're here to wrap it up at the end and talk about unilateral hearing loss. Only we're going to spice things up a little bit, and we're going to go at this a la Mythbusters. Here are my disclosures. So we're going to talk about some myths about unilateral hearing loss and cochlear implantation. Some of the things we want to tackle are the myth that children with SSD are just fine because they have one good ear. You can just fit them with a cross or a bone conduction or a remote mic or preferential seating, and that's all that they really need. That a CI doesn't help and it only interferes with that better ear. The kids with CIs and SSD hate their implants and don't wear them. That children with SSD who are over a certain age or a certain length of deafness are not candidates for a cochlear implant. And that kids have to meet all of the FDA criteria before they can be referred for a cochlear implant. And we're also going to talk about early implantation in kids with single-sided deafness. So our first myth, children with SSD will be just fine because they have one good ear. Jamie's given that the stink eye. So we often think that children with unilateral hearing loss are just fine, and we expect that they're going to learn to listen, talk, and function with just one normal hearing ear. But we know from the literature, and we have known from the early 80s, back when I was learning to ride a bike, the work of Bess and Tharp showed us that between 22 to 35% of kids with unilateral hearing loss end up repeating a grade. 12 to as many as 41% need additional support under an IEP or an individualized education plan. But there's also evidence suggesting that they struggle cognitively and with language as well. We know that kids with profound unilateral hearing loss in particular will perform more poorly on measures of expressive and receptive language when compared to their peers with normal hearing in both ears. There's a 2013 study by Dr. Liu et al. It's particularly interesting because she looked at pairs of siblings with and without hearing loss and followed them longitudinally. What she found was that the siblings with unilateral hearing loss struggled more with language and had higher educational needs than their brothers or sisters who had typical hearing in 2 ears. And of course, we know that kids who aren't able to hear from both ears struggle to localize sound or know where sound is coming from. Kids with unilateral hearing loss use more effort to understand speech and to communicate. And this can lead to challenges with quality of life, with fatigue. Audition is ingrained in our everyday function. It's ingrained into our neural function. And so unilateral input from a very early age might negatively impact higher level brain functions, such as executive function, auditory memory. There are multiple studies that are listed here that support those theories. And you may find that children who are struggling with that auditory attention, even sensory motor control, we see that a lot in the clinic. These neural changes can be long lasting. And in fact, studies have shown that this imbalance of input can result in cortical reorganization. So let's talk about what kids with single-sided deafness who do not have any assistive technology are doing in their everyday listening situation. So with just one normal hearing ear. On this graph, you can see the percent correct scores for CNC word scores. So it's a repetition of single words. We obtain these in the sound field. And blue are the results from the lighter blue is the kids are the normal hearing peers. They were age matched and they have typical hearing in both ears. And in the darker blue with the triangles are kids with just the normal hearing ear that have unilateral hearing loss. And there actually was a difference between scores. We found that children with normal hearing in both ears actually have better word recognition in the sound field and in quiet at typical conversational levels than children with single-sided deafness who aren't using any sort of technology. So even when children are in the most controlled, quiet conversational listening environments, children with SSD are already at a listening advantage. So a lot of times people wonder, well, how does this really impact? What is this like? So I like to use this example here. It's just listening to a story about cheese, because who doesn't like to talk about cheese? We'll start playing this video and I want you to listen with 2 ears, and then you'll be prompted to either take out an earbud if you're listening with earbuds, or to put a finger in your ear to kind of simulate unilateral hearing. And then it'll prompt you to go back to binaural hearing so you can just compare.
Before empires and royalty, before pottery and writing, before metal tools and weapons, there was cheese. As early as 8000 BCE, the earliest Neolithic farmers living in the Fertile Crescent began a legacy of cheese-making, almost as old as civilization itself. The rise of agriculture led to domesticated sheep and goats, which ancient farmers
Didn't mean waiting for that to start over again, but hopefully that gives you a little bit of an insight into what it's like, just the more effort that you have to use to listen, and especially learning, because I bet you didn't know that cheese started way back in the Fertile Crescent that we talked about in what, 4th grade. But if you're learning these things and these are new concepts for you and you're already putting forth a lot of effort to listen, it can really impact your learning. So our first myth, children with SSD will be just fine because they have one good ear. We're going to call that one busted. Our next myth, across a bone conduction hearing aid, a remote microphone, preferential seating, any of that is good enough. We like to call this the let's give them everything but binaural hearing method. Adam doesn't think this one's a good idea. So since we're talking about myths, I'm going to introduce you to some mythological creatures here that are going to help illustrate these concepts. So Hercules here has a good side and a bad side. And when we put him in a classroom, and all we do is move him closer to the teacher, or perhaps we have that teacher wear a remote microphone, or maybe we put a cross on that on our listener, or we put in an FM system. All those things are great, but it doesn't change the fact that he's still a unilateral listener. These are great workarounds. They're wonderful supports that should absolutely be in place for any child with hearing loss, but it's really not treating binaural hearing. It's not treating the real root of the problem, which is only being able to hear with one ear. So what about that cross aid? What does that look like? We'll put a cross aid here on our little friend. So in this situation, we're going to take the signal and we're going to send it from the poorer ear to the better ear. This is great. It gives better audibility of speech from that poorer hearing side. Unfortunately, it also does the same for competing signals like noise. So it's taking that noise that we don't want to hear and it's transferring it to the better hearing ear as well. Another issue is that we typically have to wait till 7 or so is when most people will consider fitting a cross, because the kids just need to be able to control their environment. So they know where that noise is coming from, which I think is probably an overestimation if you've ever met a 7-year-old for being able to do that sort of a thing. And we also don't want to occlude their better hearing ear. So their ear has to be big enough to be fit with a device. So what about those bone conduction aids? Well, it's essentially the same thing, only we're transmitting sound through bone conduction. We don't have to worry about the occlusion so much in this situation, but it's still going to take that noise and bring it over to the better hearing ear, because when you stimulate via bone conduction, you're stimulating both cochlea. One doesn't work, one does work. So whatever comes in is going to go to that good side. So cochlear implantation, what happens here? CI is really the only option for binaural hearing. It's the only way to get sound from both ears to the brain. So for true binaural hearing, we need stimulation from each auditory nerve to reach the brainstem so that timing and level cues can be sorted out. Routing the signal won't give you that. It won't give you summation. It won't give you squelch, all those higher level binaural hearing skills. There's evidence that that lack of stimulation to one ear during childhood can cause cortical changes, and we want to avoid that as much as possible. So the only way that you have to be able to introduce hearing in 2 ears is with a cochlear implant. So we're going to take this myth, and we're going to call that one busted too. So what about the theory that a cochlear implant doesn't help and it can interfere with the good ear? Well, we did a study to look at just that. We call it the COOL study, cochlear implantation in children with unilateral hearing loss. Our goals were to look at the benefits of cochlear implantation in kids who were preschool, kindergarten age, and had unilateral hearing loss. And we were able to compare their outcomes to a group of peers with typical hearing in both ears. We began enrolling in 2017 under an investigative device exemption. Dr. Kevin Brown from our institution was the primary investigator. And this was a prospective clinical trial. We followed these typically developing children who are between 3.5 and 6.5 years of age when they received a cochlear implant. They all were typical implant candidates in the ear to be implanted. They had no evidence of ossification or cochlear nerve deficiency. They each received a Med-L synchrony device, and we followed them for 2 years. And then we also had that group of same-aged peers to compare them to. So here is what word recognition in the implanted ear alone, how that developed over time. So we looked at those changes in those CNC word scores over time, just that deafened ear. We're plotting here increasing post-activation intervals, and then higher score is better here. So first we see what we already know. When they are listening with, my little laser pointer, and they're listening with just a hearing aid, they're really not able to understand anything. We had this one overachiever right here, but for the most part, none of our participants were able to even get pattern perception with a hearing aid. But as early as 3 months after activation, we already start to see an increase in those scores. And that continues till about 9 months of use. And then it stays stable. They continue to understand speech better in that implanted ear alone, all the way through 2 years. But we see a lot of people who are measuring success with just single ear word recognition. And nobody came to you. None of these parents are saying that they want the kid to be able to talk on the phone in their poorer hearing ear. They want them to be able to localize, hear better in noise, less fatigue, those sorts of things. So we need to put into our protocols measures where we are actually looking at those outcomes. One of the things that we put in our study was masked sentence recognition, and this is something that's doable in any clinic setting. So here's what our booth looks like. We have one speaker in each corner, 45 degrees apart. We'll simplify that for us a little bit. We're going to stick our little guy right there in front of that speaker, equidistant from each speaker. And in this example, his left ear is his deafened ear. So the first thing we're going to do is we're going to send speech out in front. So speech is going to come at both ears at the same level. We're also going to introduce noise at the same time. So again, the left ear is the deafened ear, but we have an equal signal to noise ratio on each side. So that speech and that noise are at the same level on each side. When we put a cochlear implant on, we hope to see that that improves. So binaural summation is a measurement of when you're looking at speech and noise in front, and you're comparing CI off versus CI on. So that's something that you can measure in the clinic. We also like to do this to show that the cochlear implant is helping, not hurting. And our next condition, we're going to send that noise to the poorer hearing ear, but speech is going to stay in front. So at this time, their head is actually creating a shadow. So that's when that noise is hitting their head, it's not going over to the other side. So there's a better signal to noise ratio at their better hearing ear. We put a cochlear implant on that side. We're able to measure the squelch effect. So that's comparing CI off versus on when speech is to the front and noises to the poorer hearing ear. But you can also look at spatial release from masking now, because you have that score of speech front and noise front, and you can compare it to speech front noise to the CI ear. So we want to see that scores improve once you move that noise to a separated condition from the co-located condition. So then we just take our little friend and we turn him to face the other speaker. Now we have noise coming towards his better hearing ear. That better signal to noise ratio is happening on his deafened side. So this is where you see the most bang for your buck. When you put the cochlear implant on, scores should really improve when you're comparing CI off versus CI on. And again, this is where you can measure spatial release from masking. You should really see a big difference here, CI on versus CI off, because they're able to access that better signal to noise ratio with their cochlear implant on, but they're not when their cochlear implant is off. So here's what our outcomes look like. I'm going to bring Poseidon in here. So up at the top, it's going to show you where noise and speech are coming from. And then on the bottom, it'll show you where speech and noise are in the booth and what direction our subject is facing. So the plot here is going to show you those BKB SIN scores. So a lower score is better. What signal to noise ratio is needed to be able to understand about half of what is said. So we're going to look here at our typical hearing peers with normal hearing in both ears, our SSD group with their normal hearing ear alone, so CI off, and our SSD group with their CI and their normal hearing ear, listening with 2 ears. We're going to separate this out by masker location, so speech front, noise front, speech front noise to the left or the CI ear, and speech front noise to the right or the better hearing ear. So when speech and masker are presented in front of a child, we expect there to be a certain signal to noise ratio. It's kind of our base. That's the signal to noise ratio that's required to understand what half of what is said. We call this the SNR 50, lower is better again. And with kids with normal hearing in 2 ears, it's really not all that tough. And even for kids with bilateral, with a unilateral hearing loss, they do pretty well in that condition as well. But once the speech and the masker are separated, with speech in front, masker at the poorer hearing ear, we've improved that target to masker ratio at the ear contralateral to the masker. So they're better hearing ear. So they can tolerate an overall lower signal to noise ratio. We see their score improve. So you can see there that their score is lower. That's that spatial release from masking that we're looking for. And for kids with SSD, it works pretty well when the masker's at the poorer hearing ear, but if you can see here, it's really still not as good as kids with typical hearing in both ears. When the masker's at that better hearing ear, target to masker ratio is better at the poorer hearing ear, which they cannot access. We actually see scores get poorer in kids with single-sided deafness. They've increased, that SNR 50 has increased. But when kids have normal hearing in both ears, we see an equal amount of spatial release from masking, whether the masker is at either ear. So when we compare those two groups, what we saw was no significant difference between the two groups in the speech front, noise front condition. But we did see that there was a significant difference in scores in both spatially separated conditions. So kids with normal hearing are doing better with those spatially separated noise. So now we're going to give him a cochlear implant. And we saw an improvement in scores in all 3 conditions, which is really wonderful. It's important to note, though, that they are still performing significantly more poorly than their peers with typical hearing in both ears on those spatially separated maskers. So we want to remember that a cochlear implant is going to help, but it doesn't make them a typical hearer. They still are going to need those supports to be able to perform and have some relief in the classroom. Localization. This is one of my favorite topics. So this is what our setup looks like in our lab. So we have 11 speakers in an arc. Each of those speakers are 18 degrees apart. And we sit our participants right there in the center, and they wear a cool little headlamp. We have a picture of an animal over each one of those speakers. We turn off the lights. They listen to a 200 millisecond speech burst at 70 dB SPL. They turn their head toward the speaker they think it comes from. They light up an animal, and then we are able to know the difference between where the sound came from and where they think it came from. So we're able to make a score there. We tell the kids they're going on a safari and they can't let the animals get away. They all really enjoy it. We do too. So the root mean square error is what we're looking at here. So again, this is a score where the lower score is better. We measure that in degrees. And then across the bottom here, we're looking at test age. How old were the children in years at the time we were testing them? And we're going to look at normal hearing in both ears. The SSD kids with the CI and their normal hearing ear together, and the SSD kids with their normal hearing ear alone. Again, we have age across the bottom. So what we see here is that we have a different color for each test interval. So it starts with purple and then it moves all the way to yellow over time. And each child is connected there with a line. It's kind of hard to follow, but you can see the general trend is that with this cochlear implant off, these are our scores, and then it improves. It gets lower, even at that 3-month test interval. So purple is just after 3 months of listening, comparing with CI on and CI off. But what's really interesting is even these older kids, so these kids who are implanted at older ages, they are improving as well. And their trajectory actually looks a little bit steeper than our younger kids. And what's even more exciting is this is the range of our typical hearers. And we have 6 kids who are performing within that range. But it's also important to remember that the vast majority of the children are not performing within that range. They're doing significantly better, quite a bit better, with their cochlear implant on, but still not as good as their peers with typical hearing in 2 ears. So this one I like to show so you can watch performance improve over time. So this is our little matrix. This is the response here. So, and this is the source. So if our source was 0 degrees, we made that noise right in front of them. If it was plus 90, it was all the way to the right. If it was minus 90, it was all the way to the left. Their response is where they thought it came from. So minus 90, they thought it was all the way to the left. 0 in front, plus 90 all the way to the right. So we have with the CI off and CI on, and we're going to go through and look at different intervals. So if everything is doing just hunky-dory, this is our line of agreement. This is where we would see all those bubble dots. So what we see here after 3 months of use is that when she's listening, she's just thinks everything is at her better hearing ear. She thought everything was to the left. No matter where that sound came from, she responded to the left. When she has her cochlear implant on, though, even though she's only been listening for 3 months, she's starting to lateralize. So she's starting to be able to tell if it's at the left or at the right. As time goes on, it improves even more at 18 months. And at 24 months, she's pretty much spot on. So you can see some pretty dramatic improvements in localization. And that's something that's really important to parents, especially when it comes to safety. So does a CI interfere with the good ear? We don't see any evidence of that. Not yet. Could happen, but not yet. We haven't seen anything yet. Next myth, kids with SSD and a cochlear implant hate their implants and become non-users. Well, we collected subjective data as well. So when we look at the pediatric quality of life fatigue scale, we used the parent version for this. We looked at these early intervals. So here we have our fatigue score. So a higher score means less fatigue, which is kind of hard to wrap your head around. But we see here we have cognitive levels of cognitive fatigue, general fatigue, and sleep fatigue. They didn't really change significantly over time, but we ran into some issues here. So almost all of our kids started kindergarten during the course of the study, which is very exhausting for children. But then we also had that whole COVID thing, which I think we're all still tired from. So there was a lot of other reasons for these kids to be running into fatigue, and it was kind of hard to measure. And most of the families even made comments once they were at the 3-month test point that they wanted to go back and take it again because they didn't realize how tired their children were until they weren't tired anymore. And we're talking about kids who we enrolled who were like 6 years old and they were taking naps after school. But one of the things that we did learn from these data were that parents feel that their children are most significantly impacted by that cognitive fatigue. So that's that learning in school that's most exhausting for them. It's followed by general fatigue, and sleep fatigue wasn't so much of a problem for them. They're getting enough sleep. The burn benefit scale, this is another one where higher would be better. So this is comparing CI on versus CI off. There are 10 different questions, and the parents respond, do they think they did better with a cochlear implant? They're going to rate higher. Or do they think they do better without a cochlear implant? So they're going to rate lower. So when we look at the kids who were using some assistive technology preoperatively, they could take it or leave it. Most of the time, they really weren't seeing any benefit, and sometimes they even thought they did more poorly with the device on. But at 3 months post-op, we see a big jump here, and again, we maintain that improvement over the 2 years of the study. The SSQ, Speech Spatial and Qualities Scale, this we also gave parents as proxy. Higher score is better here. They give a whole bunch of different situations, and parents respond how well they think that their child is able to function in that environment. So again, we saw this trend for improvement over time. It surprisingly did not reach significance. There was only a big jump from the pre-op to the 3-month test interval, but they kept that benefit over time. And we saw here that, not surprisingly, kids were most affected by spatial hearing. Subjectively, they felt that that was the most difficult thing. So when we look at these subjective outcomes and we ask ourselves if kids with single-sided deafness hate their CIs and become non-users, that's not typically the case. We do see non-users. There are some non-users, and we'll talk about that in a minute here. But we don't want to overgeneralize that to all single-sided deafness kids. So now let's talk about that children with single-sided deafness who are over a certain age or have a certain number of years of deafness not being candidates for a cochlear implant. So we looked at all of our kids who have a cochlear implant retrospectively in our database. So that's 100 kids that we have implanted so far. When we look at outcomes, so if we look at just single-sided deafness, just in the ear to be implanted, their ability to understand speech, we didn't see any impact of age activation. But we did see an impact of duration of deafness. So a longer duration of deafness led to poorer scores. Time since activation, so over time, they performed better. And hearing hours percentage. If hearing hours percentage isn't something that you're familiar with, it's something we use at our clinic that compares the number of hours that a child is listening, they have access to sound, compares that to the hours that a child with typical hearing would have access to sound. So when we're looking at speech and language outcomes and we're striving for typical scores, we want to compare, okay, how long do you have access to that sound, though, when a child with typical hearing might have access to sound for 12 hours, but you only wear your implant for 8 hours, you're missing out on 4 potential hours of listening. What's cool about using the HHP in this concept is it tells you about how many hours are dedicated to binaural hearing or bilateral hearing versus unilateral hearing. We also looked at that spatial release from masking. We didn't see a significant impact of age at duration of deafness here, or duration of use. The only thing that was a significant predictor was their hearing hours percentage. The greater part of the day that they listened to with their devices, the better they did. So what predicts how well a child is going to use their device? It's not their duration of deafness. It is very much their age at test. How long it's been since they had their implant. And their onset of deafness. So children with congenital hearing loss versus progressive hearing loss versus sudden hearing loss. Kids with sudden hearing loss wear their devices more often than kids with congenital or progressive hearing losses, probably because they're so used to that bilateral input and they're very happy to have it back. So we don't see any reason for there to be an arbitrary cutoff, because we don't see that it is age at implantation or duration of deafness that's driving this lack of use. we see that it's just age. Teenagers with single-sided deafness don't want to use their implants. And that's not all that surprising. We take this invisible disability and then we put a flashy, shiny thing on their ear and make it visible. Teenagers aren't going to be all that keen on that. They also see this in kids with diabetes who don't want to wear their insulin pumps, or kids who use CFOs. Once they become teenagers, they don't want to wear those either. So it's not just cochlear implants where we see this impact of just the teen years on how often they are using their implants. But one of the things that people are concerned with is which came first, the chicken or the egg? Did they stop wearing it maybe because it sounded poor? Well, we don't see evidence for that either. So what we see here when we look at, these are our CNC scores on this axis. And over here, we see their hearing hours percentage in blue. So here we see that their hearing hours percentage starts really, really high, and then it drops off once we get to those preteen years and it stays pretty low. We are starting to see a rise here, and we're having some of our older kids are coming back and they want to try wearing their implant again. Jury's still out on how well they're doing with that. But what we see here is that we see this drop in use before we see any drop off in CNC word scores. So their scores are improving over time as they're wearing their devices less. So that would lead us to believe that it's not the sound quality that's making them not want to wear their implants. We see the same thing with the spatial release from masking as well. We see their device use go down, but we're seeing a stable scores here. And then after their device use goes down, that's when we start to see a decrement in their spatial release from masking. So we're going to bust this one too. We don't think that the evidence is there yet to have a strict cutoff. We do feel that counseling is extremely important. If you have a teen or a preteen in your office who doesn't want to wear it, then we can't really say that the benefits are going to outweigh the risks. As much as we would like to believe that our kids are going to do what we ask them to do whenever they leave the house, it's just not all that true to be able to know that they're going to wear it all the time when they are at school. So we're busting this myth. We do not say to someone you can't have an implant because you've been deaf for 12 years, but we will say your outcomes probably aren't going to be as good. We might be just looking at sound awareness, and then it's up to them to decide if they want to go through with a cochlear implant or not. Another myth that we run into is that kids have to meet all of those FDA criteria before they can be referred. And that FDA criteria is pretty strict. They have to be over 5 years old or over. They have to have a straight, profound unilateral hearing loss. They have to have had deafness of less than 10 years and 5% word recognition in the ear to be implanted, which is pretty arbitrary. And that's 2 words on a 50-word list. Something to remember is that off-label use is a thing. This is a quote from the FDA website. That from the FDA perspective, once the FDA approves a drug, same thing for devices, healthcare providers generally may prescribe the drug or device for an unimproved use when they judge it as medically appropriate for their patient. So you don't have to meet all of those criteria. There are many surgeons at larger centers who are doing implants outside of those criteria if they think it's medically appropriate for their patient. So the big things that we see there are that it's a profound unilateral hearing loss and that 5% word recognition rule. We feel at our center that if the loss is too significant for a hearing aid, then you're a unilateral listener. And the only way that we're going to be able to remedy that is with a cochlear implant. So if somebody's a unilateral listener, we consider them for a cochlear implant unless they have cochlear nerve deficiency, which is another talk for another day. What about that they have to be over 5 years old? We all know younger is better, and we'll talk about that in a minute. There are kids we want to see as a priority for implantation when they have single-sided deafness. We don't really want to wait for the better hearing ear to drop because that is going to guarantee that they're going to stay a unilateral listener, because after a while, those outcomes are going to be really poor in the first deafened ear. When we compare that to the implant in the better hearing ear, it's going to be a struggle to get them to wear that first device and we're going to have a unilateral listener. Kids with CMV, kids with an IP2 malformation, so one of those minor cochlear malformations, they are at risk of progression. So we want to make sure we keep them unilateral listeners. If one ear drops before the other, we want to make sure we do an implant in that first ear. Bacterial meningitis, that is an immediate cochlear implant situation if they have lost their hearing, because that cochlea starts to ossify over time, and then you can't get a cochlear implant in. So we want to make sure in cases of meningitis that we're offering a cochlear implant very early. There are also some genetic factors, some genetic hearing losses that can cause hearing loss to drop one ear after the other. So we're going to bust this one too. So early implantation. Kids receive more benefit if they were implanted early. Well, we don't have enough evidence to say that yet, but we know that everything with hearing says that younger is better. It is difficult to test these kids though, but we don't want to keep that from giving a kid their best shot at binaural hearing. So some of the questions that we want to answer are, can cochlear implantation at a younger age help head off some of those behavioral concerns? Is it helpful at all? Or is this an occasion where you could wait? Is it going to be just as fine to wait till you're 3 or 4? We don't know yet. But when it comes down to it, we all know that there's a critical period for auditory development and that we can't get that time back. The argument seems to be that we wait until kids show difficulty in school before introducing a cochlear implant, but we're not a reactionary profession. We never have been, and we shouldn't be with this either. 136 is becoming 123. So if we know with that amount of certainty that early intervention is better, we don't want to leave our kids with single-sided deafness in the dust. We also know that the kid who has a hearing that starts here can become the kid who has hearing here. And let's not ignore the fact that that 2-year-old child is one day going to be a 20-year-old adult. So we need to think about long-term, what is this person going to need as a fully functioning adult in society? So would kids receive more benefit if they were implanted early? Probably. It's plausible. But there's still so much that we don't know. What about those things we talked about earlier? Educational performance, cognition, IQ, attention, their speech and language skills, and what we see anecdotally as sensory seeking behaviors. Are those things due to the etiology? Is it due to that cortical reorganization? Can we treat these things with a cochlear implant? The jury's still out. We don't know that yet. There are clinical considerations that we need to think about. That microphone on the device, is it okay to have a directional microphone on, or do we need to stay omnidirectional? What about the processor design? Do we want a processor that's ear level, or is it okay to have an off-the-ear processor and have that microphone at head level? What about that delay from the cochlear implant? Coding strategies, place of stimulation. These are all things that we are investigating, especially this place-based mapping, trying to align filters with the cochlear place frequency so that they have similar input in pitch between the poor hearing ear and the better hearing ear. So yes, we will confirm that there is still so much that we don't know. So here are our facts and our myths. So there are options for bilateral hearing. And across a bone conduction, remote microphone, preferential seating, they're all wonderful things that should be part of any child's educational plan, but it does not provide binaural hearing. A cochlear implant can help with localization, and we haven't seen evidence that it interferes with the good ear. Teenagers use their devices less than younger children, and that device use is very strongly correlated with performance. And that long durations of deafness are associated with less benefit, but not zero benefit. I think it's important to remember that as well. We got to use counseling. We have to set realistic expectations with our families. Any child with a healthy auditory nerve who can't use amplification in one ear could be referred for an evaluation. Something always to remember, you can refer a child for an evaluation without knowing if they're going to be a candidate or not. You can just suspect that they need more than what they're getting right now. So thank you all so much for your attention. Here's my email address. I'm always happy to entertain any questions and conversation, and I am available for questions.
Lisa, thank you so much for your presentation. I really appreciated the myth buster approach to this topic. It was actually very appropriate. We do have a question for you. Actually, it's a two-part question, so I'm going to ask it in two parts. What does habilitation look like post-activation at your center?
We have an evolving, let's say that, we have an evolving opinion about how that should go. I do think that there is value in doing listening with your cochlear implant alone, following an auditory hierarchy, getting that nerve up and going and listening again. But I think once you get there, you want to look towards localization, really trying to focus on those binaural hearing skills. When we do have therapy with our SSD patients, it's always remote, because even if we were to do it in the clinic, we're going to do it in a different room so that they can't hear us and we are streaming directly to their implant. For our little ones, we encourage the families to read a story to record themselves reading a story that the child is familiar with, or singing songs that the child likes, and then streaming those to their cochlear implant when you have some time to listen and work on those skills.
Great. Following along on that, how has your team found compliance with completion of home programming for this population? And in terms of parent, I would imagine in terms of parent involvement and support.
Yeah, I think it depends on the parent. A lot of times we see a lot of excitement in the beginning and then it peters out pretty quickly, because it can be really frustrating especially when you're just working on that cochlear implant, you're alone, and it's hard to watch your child struggle with understanding. And especially when you have no experience with hearing loss. So you're at a stage where they're just knowing if there is a sound or not. It's pretty frustrating to watch your child go through that. I find with our teenagers, the ones who did want that implant, they also will start gung-ho. They think it's really cool that they can stream their music to their implant and nobody knows, and they want to do it in sneaky places. But it also tends to peter out, I think. And sometimes it comes back, when they come in and their scores aren't doing as well because maybe they haven't been wearing it as much. They might go back to it for a little while. So it's in flux.
Great. That is all the questions that have been posted here. I know it's the audience stayed enwrapped with you. They stayed listening and attending. So you had a very good audience. Thank you so much for your time today. It's a really important topic, and one that I think we will be looking forward to seeing more of your future outcomes and your research as you continue on this.
Well, thank you so much for having me. It's been fun.
Yeah. And with that, the AG Bell 2023 Listening and Spoken Language Virtual Global Symposium has come to an end. Except there's a question that's now, see, I was filling time there, but another question just came in, or two. You can kind of wait till the very end. So if you're okay, we have a few minutes.
Absolutely.
Okay. So this was a comment. I'm so glad to hear you speak so concisely about this, especially looking at the educational impact. Do you have any data on direct impact in the classroom setting, or do you plan collecting that type of data?
We are planning to collect that type of data. There's also a study that's going on currently in Europe. I believe it's Germany, that's doing a similar sort of setup to a study that we're just getting started looking at kids who are at a certain age and have single-sided deafness. How are they performing in the classroom? And then when we implant children very
Is it me or?
Looks like we lost her.
Lost her. Yeah. well, we had a few more questions that have been posted. I'm sorry. Looks like we have lost our speaker for now. So maybe that's a good time to close out. And thank you again for being a part of, oh, she's back.
He's disappeared.
Well, we still have people out there and so if you were talking about continuing to look at educational outcomes.
Yeah, so we want to look at more.
I think we lost her again.
We've lost her too. So I think that the best thing for us to do would be to go ahead and close this this session out and this symposium out. Thank you so much to everyone who came from all around the world. Some of you stayed up all night long. Some of you came in and out. There's a lot to learn. I know that I'm looking forward to the on-demand sessions that I wasn't able to see, and look forward to seeing you again next year. Please, there was a note in the chat to give us your opinion and feedback on the symposium and ideas for next year. I encourage you to click on that link and provide that information. And with that, I will say good day.